All right, we are live.
Hi, everyone. Welcome to the Next Gen webinar series. I apologize for the delays, but we are joined today by Dr. Bhadelia. She is the Director of Infection Control at the National Emerging Infectious Disease, and she's Assistant Professor at Boston University School of Medicine in Boston, Massachusetts. She's an infectious disease physician, and her work focuses on identifying health systems interventions that can reduce the impact of outbreaks on communities. So without further ado, Dr. Nahid, I'll hand it over to you.
Thank you, Janicia. Let me see if I can screen share here and start the presentation. Great. Thank you again, and sorry for the technical difficulties a little earlier. I want to talk a little bit about what I'm going to be covering today, but before that, I'll just say I have no disclosures, and all the photographs are mine unless otherwise stated. So what I wanted to do today was to talk about some of the factors that are leading to the increasing emergence of outbreaks with emerging pathogens, describe some of the challenges related to detecting and responding to the 2014-2015 Ebola epidemic, and then discuss the current global health security agenda and how it will aid outbreak prevention, detection, and response. Then I'm going to go into some of the areas where I think the global health security agenda may fall short, where we may need other strategies to recommend other strategies that might address the gaps that will still exist. So as Janicia said, I'm an infectious diseases doc, but what I do is I run the medical backup program for a biosafety level 4 laboratory. It's a high containment laboratory that does research on emerging pathogens such as viral hemorrhagic features like Ebola. What I do sort of places me at this intersection between clinical care policy research and gives me this unique perspective about how to prepare not just hospitals, but also communities, and to sort of recommend to the larger public health systems what the way forward is, particularly around medical countermeasures and preparedness. So the perspective that I'm giving today is coming from that background, but also in 2014, I went back and forth from Sierra Leone and served as a physician in Ebola treatment units, 2 out of the 4 trips that I did, and then I worked with Ebola survivors, and I was able to see a lot of the on-the-ground manifestations of this epidemic. So let me start by talking about what we're really seeing. Every year and a half, we're seeing a new pathogen sort of break out on the scene. And it's not your imagination. It truly is becoming a lot more common. And the thought is that there are multiple factors that are pushing new pathogens onto the scene. One, of course, is we're potentially getting slightly better at detecting them. The other are, when I was born, there were about 4.3 billion people in the world. And if you look at the population now, it's over 7 billion. We're a lot more people in the same amount of space. And we are encroaching on reserves, on natural systems that are in balance with each other, but not necessarily with us. And that's allowing for this phenomenon called spillover, where pathogens jump from wild animals into domestic animals, into humans, and vice versa, or from wild animals into humans. So we have that trend, and that's sort of being incited by a massive amount of stress on ecological system. We see a deforestation rate at the rate of about 46 to 58,000 miles of forests are being lost every year. You're seeing increased chances of spillover happening. But then on top of that, we're seeing an increased connectivity in the global system. In 2014, about 3.3 billion people took flights, connecting us in a way that is unprecedented in human history. So a pathogen, an outbreak anywhere is a potential threat everywhere. And really sort of getting to the heart of the fact that our security, our health security is connected. We also see the same sort of connection in the food that we eat, where it's produced, where it's reared, how it's shared, which I think the prior webinar covered. So going to the Ebola outbreak, Ebola is a pathogen, as you may know, was discovered in 1976. And between then and the 2014 outbreak, we had multiple smaller outbreaks, the biggest one being 426 cases in Uganda in 2000. And we went from these smaller outbreaks into this. And the question, of course, is how did this happen? How did the environment in which this epidemic appeared allowed it to spread so much farther than what we had seen in the prior outbreaks? So one of the things that I want to talk about is the initial setup for how this pathogen was discovered and the delay in the international response to the pathogen. So the index case for Ebola in the West African outbreak is thought to be in Guinea in December 2014. And it wasn't until March 2014 when Ebola was actually identified as a causative agent. And there are multiple reasons for that. One is, this happened in a rural area. Even when the outbreak was detected by MSF, the clinical symptoms are thought to be potentially something that looked like a diarrheal disease. What complicates a lot of these outbreaks that occur in rural areas in resource-limited settings is that there are no laboratory diagnostics available. So people can die of pathogens that look like every other disease that's endemic in that area, and you may not be teased apart something that's a rare pathogen. And in this case, it wasn't until March that suspicion was evoked and resources were available to identify Ebola. In June 2014, the outbreak had already spread into 3 capitals in West Africa. In August 2014, now we're talking about, months after the, over 6 months after the initial index case, WHO finally declared the public health emergency of international concern related to the Ebola epidemic. And the bulk of the resources, the financial resources, actually did not get committed until September and October of 2014. Now on the right, when you see these this chart of where the cases were there, you can see that we were well along at the peak of this epidemic, when the bulk of the resources came in. So what were some of the challenges on the ground? As both a public health practitioner and a clinician, some of the major challenges for us were, the first time I was in the field was August 2014, and there was this immense dearth of human and physical resources. In the Ebola treatment unit that I worked in August 2014 in Kenema, Sierra Leone, there were about 4 expat clinicians, 4 or 5 expat clinicians, and about 8 local nurses per shift to 100-something patients. And to sort of balance that out, Emory had 1 patient at any one time, and they would generally have the inverse ratio. They'd likely have 50 to 100 staff taking care of that 1 Ebola patient. Ebola is a disease that's high in nursing needs. You require to be at the bedside because patients lose a lot of their bodily fluids, and it requires a intravenous or oral rehydration that is labor intensive. And that dearth of human resources really impacted our ability to provide that care, and likely it was related to the high mortality. But also, I think because of that high mortality, the initial distrust and the fear that was in the community about what is the gain of actually going into Ebola treatment units when it's a death sentence no matter what. I think that with better resources, human resources, physical resources, we could have turned that around. On top of that, we were limited by the amount of time that we could spend in the hot zone because of the limits of personal protective equipment. And we were unable to maintain the level of infection control within the Ebola treatment units as we would like to, because there were so few hands around to ensure that people were being kept in a clean environment. Other than that, there are also impacts of the infrastructure issue itself that affected the care. What was available in terms of diagnostics, what we could actually use within the hot zone, the dearth of resources within the healthcare system itself before the outbreak started, the lack of enough healthcare workers before the outbreak started. And then this was an interesting part that many folks may not realize. When you have a natural disaster, you're able to respond to it by setting up an emergency operations center. You set up all your resources, you set up all your
Sorry, everyone. It seems like we might have lost Dr. Bhadelia. Hopefully she joins the call again real quick.
Okay, good. Got
Hey.
me. All right, good.
Got you back.
Good. Let me try this again. Okay. Can you hear me now?
Yeah, we can hear.
All right. So going back to this, so when you have a natural disaster, you're able to sort of set up your response system. Now imagine a scenario where the threat actually shifts. Every few months you set up your system, and already a healthcare system that's, as I mentioned, the dearth of a lot of resources, and you have few resources in the field, and now you're getting shifted, 10 miles this way, 20 miles that way. The epicenter was in Kenema in Sierra Leone in August. By November, it moved to Port Loko, and then in Kono later on that year. And so that kind of complicated the response as well. Additionally, we did not have the infrastructure to get timely labs early on, which kind of delayed the amount of time that people were in the suspect ward. People are admitted in Ebola treatment units when they presented with symptoms that might be consistent with Ebola. But Ebola can appear with nausea, vomiting, fever. And it's very similar to everything else that might be endemic in that area. So you might have malaria and be waiting in the suspect ward. And if you didn't have Ebola before, you might be exposed to it now. So that dearth of timely lab reports really impacted the safety of folks who may not have had Ebola that ended up being exposed to it in Ebola treatment units. We also had very poor data quality coming out of the Ebola treatment units, but also in the field, partly because, again, tied to the lack of human resources that we had available to do case finding, to do contact tracing. And to add to all of that, it was an environment where West African countries, and particularly Sierra Leone is my experience, you have a country that has had a lot of distrust in governmental structures. There was a civil war there in the 90s. And what the communities saw, having had no prior experience to this, are all of a sudden these roadblocks that went up, these white tents, tarp tents that got put up, and their family members were being taken into isolation and in most cases not coming out. And to add to that, there was a detrimental effect of what's been called the international epidemic of fear. In the US, if you had talked to a public health expert during the height of this epidemic, they would have said the chances of getting Ebola in the US is 1 in 13.3 million. But you wouldn't have guessed that looking at the media response, the response of some of the public health bodies and also mostly the public as well. Because of that response, for example, in August 2014, the first time I was down there, many commercial shippers stopped flying. Many commercial airlines stopped flying. So the dearth of human and physical resources were even more pronounced because nothing new could come into the field until new supply chains could be set up. And so that detrimental impact really sort of exacerbated the response itself. But the way that we've related, the Ebola epidemic, it's the latest in a stream of diseases that have caused concern at the borders between countries, whether it be cholera or it be yellow fever. We as sovereign nations have for a very long time been talking about how we deal with each other. How and if we are beholden to each other when a disease occurs within our borders. And earliest on, you can sort of see agreements such as the International Sanitary Conference in Paris in 1851 that already started talking about intergovernmental cooperation and the setting up cholera outbreaks in Europe in 1830s and 1847. And even at that point, they talked about issues such as quarantining areas and countries when there's an outbreak going on, with the understanding that any action that's taken against a country can impact its trade and travel, and in time may impact you yourself if the outbreak exists within your borders. So what is new about global health security? I want to go back to what's changed. If we've been talking about this across the board, what does the global health security agenda and the global health security field really add? I want to go back to where the term global health security, or health security in particular, comes from. It stems from the field of human security. Human security is a field that was first really took form when it was mentioned in the Human Development Report of 1994. And it was defined as this idea where it's thought to be one of two main aspects. First, it's safety from chronic diseases, threats such as hunger, disease, and repression. And second is protection from sudden and harmful disruptions in patterns of daily life, whether in homes, in jobs, or communities. The reason why the term human security was brought up was because it's a juxtaposition to national security. Human security refers to the fact that you could have safe borders, but humans within those borders could still be completely insecure. Communities could be completely insecure. So the referent object here was, how do we protect communities from threats that might destabilize the country itself? The Ebola epidemic had an immense impact on both the GDP, the economic growth of the countries in which it was it really wreaked havoc, but it also is going to impact for many, many, many decades to come the healthcare indicators. You know, the loss of healthcare workers, the sending resources from one area of the healthcare system to really respond to the epidemic in another area has really sort of strapped the already struggling healthcare system in these countries. And so the thought is that factors such as maternal mortality and infant mortality might be impacted. So this idea of economic stability and health stability because of outbreaks is one of the reasons why health security has been so important, because it's referring to threats that go within borders that national security cannot really address. And so what it's really done is it expanded the types of threats that should be considered as national security threats: hunger, disease, environmental degradation, things that can destabilize, even in the absence of conflict, which is the traditional national security realm. And it increased the number of actors that are a part of this discussion about national security and security studies in general. And it included now actors coming from civil society, non-governmental organizations, and international governmental, non-governmental organizations such as WHO, World Bank, IMF. And in the end, the discussion's always been, how do you define health security or human security? Is it that you are how is it different from development? If we're talking about trying to keep people from things like hunger, disease, environmental degradation, how is that even any different from development, right? And so some have tried to more narrowly define it by saying these are acute disruptions versus ongoing issues. And others have wanted to define it a little bit more broadly, really saying that we need to identify those aspects even of development that increase the risk of getting hazards to become disasters. What are the factors that increase resilience against these? So health security, and you can see sort of the factors of human insecurities and health security insecurities under that. And epidemics has always been considered one of the major factors of health insecurity. Others being those systemic issues that can give rise to epidemics, but also to poor health in general in countries that are affected. So the evolution that led up to the global health security agenda, as I mentioned, has been long coming. And in 1969, the way we think of the modern international health regulations really came into being with strengthening of that, with more of a focus on limited number of diseases such as cholera, plague, yellow fever, smallpox, relapsing fever, and typhus. And then a lot of that was focused on narrowly on how do we come up with policies that make sense from public health perspective, but also diseases that might have potential adverse consequences for international trade and travel. And that idea of how are countries beholden to each other, and the fact that diseases might actually affect national security, was expanded even more in 1995 to 2001. Really the field of health security started being defined by the HIV epidemic, and this idea that when you have countries with high prevalence of this epidemic, you're taking out some of the largest labor force, the national security forces, the healthcare workers, and you're destabilizing entire countries from a pervasive epidemic. And then in 2001, the anthrax attacks in the US, as well as in the SARS epidemic in 2003, really led to, in the aftermath of those two events, the reevaluation of what are we asking countries to ensure? How are we beholden to each other? And the revision of international health regulations in the mid-2000s and 2005 really expanded what IHR was asking countries to do. Now the ask was that countries create capacities that allow them to prevent, detect, and respond. Already, a lot of the concepts that we see in global health security, to new threats within their borders from emerging infections or even endemic infections, and then to report those to WHO and to work with WHO to respond to those threats. And then after the Ebola epidemic, I think that the global health security agenda had been sort of being developed throughout this idea, but it was revived after the Ebola epidemic even more, given the fact that this epidemic really pointed out the fact that even if the disease cannot be, Ebola is not the most, when it comes to spread across borders, it can do that locally. It doesn't have as much of a international impact from what we know, as opposed to things like pandemic influenza. However, it can still have devastating impact on trade and economics and just security in general, from things like the epidemic of fear. So what can we learn? So the global health security agenda, I'm going to talk about what the current global health security agenda is, but I wanted to step back. Since we know that the global health security agenda and health security agenda comes from this human security field, what is this human security approach? What is the global health security agenda really adding on top of public health or development, economic development in general? So one concept, the human security handbook defines this human security approach as something that is people-centered. It's really, again, it's within borders, it's focusing on communities, it's comprehensive. It goes beyond particular fields to really look at dynamic intersectoral factors that are creating these vulnerabilities, that are detriments to resilience. Also, it's context specific. It looks at the particular threats, but the responses are very much context specific to what the scenario is. It's prevention oriented, and it's tied to prevention oriented, at least for infectious diseases. It's around protection of safety and around empowerment of communities to ensure that they can increase their resilience to these threats. So this is the current global health security agenda. What I think it does, and what it adds to the international health regulations, is that majority of the countries, many of the countries that are under the IHR, that signed on for the IHR, actually did not have the capacity to be able to meet the requirements that IHR had set up. And beyond that, there really just wasn't an understanding of where they were lacking in those capacities. What this particular agenda does is it's a cooperation of 50-something countries, nonprofit and academic partners, as well as international nonprofits. And among different steps, the first step is external evaluations to assess national health security capacities of countries that have agreed to be part of this collaborative. And the thought is that by doing this, we might be able to better determine the baseline capacities. We're going one step further. We're saying, how can we help increase? What are the gaps? How can we help increase the resilience of countries that might have devastating impacts from emerging infections or outbreaks in general? So what it's meant to do is inform the development of roadmaps, measure progress and work implemented under the international health regulations core capacities, again, the capacity to prevent, detect, and respond, and then to highlight gaps that would allow priority setting, and tied to that, I'm guessing also funding priority setting. So the way that the current agenda is set up is prevent, detect, respond, and under prevent, it really is focusing on factors that lead to emergence of zoonotic disease, emerging diseases. And one point to make that I didn't make earlier is that majority of the novel emerging infections are actually something we call zoonotic diseases. 2/3 of new diseases that we're discovering are diseases that jump from animals to humans. So it's really taking, just as the human security approach suggests, a comprehensive intersectoral approach to saying where do these diseases arise from, and is looking at the human-animal interface. It's looking at how do we improve laboratory capacity so that we can pick up these pathogens early on and really respond to them. But at the same time, how do we balance that with making sure that those laboratories can do their work safely, so biosafety, and that the work that's being done in these laboratories doesn't fall in the wrong hands, which is biosecurity. And it's working on increased surveillance, reporting, and workforce development. And then on the response side, it focuses on emergency operations, building emergency operations centers, public health and law enforcement, and then medical countermeasures and personnel deployment during outbreaks. For example, foreign medical teams to help supplement the national responses to outbreaks. So this particular global health security agenda only a couple of weeks ago was actually reaffirmed by President Obama, and this executive order basically reaffirms the commitment to the global health security agenda. But the National Security Council, under this executive order, is to assemble a global health security interagency review council. And the order also describes how different U.S. agencies will collaborate and what they will focus on. So what do I think that the global health security agenda or the health security approach really adds on top of public health or on top of development? I think that it creates, going along this path that we've taken with international health regulations and progressively sort of become an interconnected world, I think it creates yet a known scaffolding for cooperations between states that are familiar under traditional security agreements, but is tackling new kind of challenges, if that makes sense. It's allowing countries to collaborate in standard operating procedures that already are familiar under traditional security agreements. And then it has a lot more to do with governance and implementation than the development itself or the public health aspect itself. It focuses on proactive, preventative, and institutionalized responses. It also, and I'll talk a little bit about what all these things mean, it assesses risks by addressing vulnerabilities to hazards. It really is looking for the gaps of where things are falling through. And then it allows for interdisciplinary approach, including, as I mentioned in this case, things like One Health and the inclusion of animal and planetary health actors. So how is it different from public health? The one way that and this has been argued for a very long time, what does health security have any added benefit to go to public health? Why are we taking potentially resources away from public health and existing health, programs, public health programs? One way to think about it is that I think it's a lot more focused. If public health is, for me, is the science of preventing disease and promoting health, and global health security is the discipline focused on preventing the gaps, stops, and injustices in the system that promote public health. So, and not only that, but, and this particular WHO graphic sort of explains it a lot more. It is focused a lot more on governance. It's policy driven. So if you look at the left, it's health security on the bottom blue Venn diagrams, as you can see, where health security has to do a lot more with global health agenda that we just talked about, global health security agenda, international health regulations, and these evaluation tools. And it's linked to building continuing work that public health folks are doing with resilient healthcare systems, essential public health functions, health systems financing, workforce. And so it's really meant to help facilitate policy and governance and cooperation around this, and to really highlight those aspects of existing development in public health work that can help really decrease our vulnerability to epidemics. So what do I mean when I say that it addresses gaps and such? So the way to think about it is that, hazards are unavoidable. I mean, you could work on decreasing hazard. For example, you could decrease they're harder to work on. You could decrease the environment under which new pathogens arise. So one thing would be to have better environmental justice, to have decreased impact to the climate that actually drives a lot of the things that we're seeing now. But that's very hard to do. And from what we understand for a lot of the major factors, such as even climate change, which is driving a lot of emerging pathogen emergence, is that when you look at climate change, the impact that we're seeing right now with warming of the environment, one example of how this can impact emerging diseases is changing the density of vectors. So mosquitoes are now presenting in new areas or in expanded areas or at greater density in areas than they were before. And so they're carrying the diseases that they normally do to new areas as well. We know that the current changes have happened because of the carbon emissions that happened about 30 to 40 years ago. It takes about 30 to 40 years for carbon emissions to be put in an environment for the temperature to increase to impact climate change. So what we're seeing now as changes are things that come from emissions 30 to 40 years ago. So we already know that the hazards that are coming down the pike are actually going to be a lot worse. And so we can't necessarily impact some of the hazards. But we can figure out what the risks are. Where are the highest areas of vulnerability? What are the risks that these climate change or increased deforestation or overpopulation can cause, or many other factors? And then what exactly, when we're presented with this risk, what exactly are factors about that inherent situation that create the vulnerability? And this particular example is actually taken from environment and human security, but the same can be applied to health. What factors within the healthcare system improve its resilience to the hazards of emerging pathogens, and the risks, increase the risk of it? So from that perspective, I think global health security is a focused and novel way of cooperation, and it's really looking at the factors that are creating the greatest amount of vulnerability. But there are a few things that I think that we will continue to sort of need to pay attention to, where the current global health security agenda, it will take a while either to be able to reach that level of improvement to decrease those vulnerabilities, or it may not, it doesn't necessarily fall under the current agenda. So one example is we're focusing on particular aspects of healthcare systems, as I mentioned, and I've mentioned some of the factors that we're looking at, which is workforce development, increased active surveillance, increased reporting of diseases, increased laboratory diagnostics. But what we really need, all those things are being put into an environment where a lot of countries actually do not have strong healthcare systems to begin with. To build healthcare systems for every country, resource-limited country, it's a behemoth of a job. It takes a very long time. It's not something that will happen overnight, even though these pathogens and these outbreaks are happening every day. And so what you're really seeing is, for example, let me give you the example of Nigeria. Nigeria, what you're really seeing is that there are certain aspects of healthcare systems that more actively be able to pick up these outbreaks, but others will still pose significant amount of vulnerability because we're not going to be able to immediately improve the healthcare systems in all the countries that might have these diseases. So Nigeria, during the Ebola epidemic, was lauded for their response with the Ebola outbreak. The first, the index case in Nigeria was a traveler who came into Lagos, and the worry was Lagos is one of the largest cities in the world, and I think probably the largest city in Africa, at least. And the thought was if Ebola had sort of broken out in Nigeria, it would have been a disaster. But Nigeria was able to really quickly identify the pathogen as being Ebola by an astute physician sort of thinking this might be Ebola, sending that blood test to a laboratory at a university that was able to confirm it. And quickly, because of the existing resources that were created under the polio vaccination drives and the work between US CDC and the Nigerian CDC to build existing emergency operations centers, they were able to quickly follow all the contacts of the person who was sick, and they were able to find new cases among the healthcare workers that were exposed to this traveler and really contain this disease. Okay, but now use the example of Nigeria and Lassa fever. Lassa fever is another hemorrhagic fever that is endemic. It happens seasonally in Nigeria, but last spring, they had a major outbreak that was bigger than usual. But the more worrisome thing is that it was causing a lot more mortality than previously expected. But when you spoke to Nigerian healthcare workers and public health officials, it was really hard to get a handle on how big this disease was, how big this outbreak was. If you don't know how big the outbreak is and where it's occurring, you can't really make a good public health strategy. And these are the exact scenarios under which outbreaks sort of expand and move beyond borders, correct? And so the issue was that whereas Nigeria was very good because of active surveillance, when you know that there's disease in the country, you know where it is, in a limited sort of number of people who are impacted, you can do active surveillance. But only something like a good healthcare system that can allow sick patients to quickly access care, and if you access care, be counted as somebody who's sick, and in those healthcare centers be able to run that laboratory test to confirm that disease. Can you really have a continuous, ongoing surveillance for emerging pathogens? So my point being that the lack of strong healthcare systems is always going to be a blind spot in our fight against emerging infectious diseases. And the way to think about it is that the terminal end of all international surveillance for emerging pathogens are communities that are lacking for care. If someone who is in a poor community in Nigeria gets sick, can they afford care? If they can't, is there a healthcare system close enough for them to get to care? If they do get to care, is that particular community center, is it equipped with laboratory equipment to detect it? Is the reporting of that strong enough? There are always going to be those pockets early on in outbreaks where we miss the initial 50 to 100 something cases, depending on the scenario, because they may not be able to come to the attention of the healthcare system, so or where our surveillance systems are. So that's going to be an ongoing challenge, I think, until we can improve healthcare systems in general. So what we really need, I think, is new innovative approaches to rapid continuous surveillance. So not just that, something ends up in our net, so we can pick up a certain number of diseases if someone comes to a tertiary care hospital. We need better approaches to pick up outbreaks in really rural, disconnected communities. And when you look at where a lot of the spillover is happening, a lot of times it is happening in a lot of rural areas. And so I think that's going to be an ongoing issue. So this particular picture is from a training of Ebola survivors that I did in January 2015. And in this picture this is point 2 as I'm moving on. In this picture, majority of the survivors were already experiencing post-Ebola survivor syndrome or disease. They were already experiencing what we now recognize are ongoing symptoms even after you've recovered from Ebola virus disease. And so particularly, in the case of, for example, when there was a returning responder to Scotland who was a nurse who, after her own survival from Ebola, months afterwards started developing central nervous system issues with Ebola. And there was a lot of uproar about how this could have happened. How could we have missed that Ebola can stay in the central nervous system months after the person has recovered? How can it be that it can exist in male sperm for months after person has survived? When we went back to look at survivors of other outbreaks, this was already always going on. All the survivors, a lot of the survivors from other outbreaks in that area, when they were followed up, were still all complaining of some of the symptoms that we saw in survivors from this particular epidemic. So what was the difference? The difference was that we go in and we respond, and that's great, we can control the epidemic. But what about after? I think that there is a detection bias, because if you're there, you can pick up how the disease is manifesting when you're there. But in the lack of healthcare systems, when you do not have longitudinal perspective of what happens to that individual patient, and because of that, it really limits our understanding of emerging diseases. if a lot of the survivors from prior outbreaks, for example, were plugged into care, we would have a better idea of the fact that this happens, that this virus can actually manifest this way. And so I think those are going to be ongoing issues. So I think what we need to do, so when you spoke about, when the Scottish nurse developed these symptoms, a lot of my colleagues who are West African clinicians said, well, we've been seeing Ebola survivors in West Africa die of these symptoms all the time. We just have no way of diagnosing them. We don't know what they're dying of. We don't have the capacity to be able to sort of pick those things up. And so I think we really need to improve the bridges between clinicians in resource-limited settings and resource-rich countries, as well as researchers in these two areas, so that we are better informed about what happens to these patients in the aftermath of outbreaks. But even before that, I think that allows improved sharing of intellectual capital and better preparedness. And that's something that I think that we can get better at, and we need to figure out what those platforms should be. Then, and this is particularly for emerging infectious diseases, by which I mean diseases that we don't know much about, and we're learning about the disease as we are responding to the outbreak, as we're taking care of the individual patient. A lot of times when you have a crisis, there is clearly, in any crisis where you have limited resources, you need to make sure that those resources are applied to saving patients, to clinical care, to limiting the outbreak. However, I would propose that actually we need to start looking at outbreaks with emerging diseases in a new way. The reason why is because in these types of outbreaks, every single patient is allowing us to learn about the disease that could improve the quality of care and outcomes for the next 100 patients in that very same outbreak. And so capturing that data and sort of really getting not just diagnostics and medical countermeasures that a lot of times are experimental because we don't see this disease, we haven't seen this disease in the past, but also simple things like how do patients present with this disease. Capturing that data better would be better, would allow us to improve not just outcomes for individual patients, but really the scope of the entire epidemic itself. So I would propose that when it comes to caring for patients with emerging infectious diseases, I think that separating research from care is actually a false dichotomy. And what I would suggest is that it's because, as I mentioned, every single patient in some ways is teaching us about this disease as we're moving on, just as the Scottish nurse taught us about the fact that Ebola can present in the central nervous system. And then I would suggest that we need to expand our idea of what this research is. It's not just diagnostics and medical countermeasures, that we need to really look at how we can improve our care for these patients, and for those reasons, are even supportive care for these patients. And for those reasons, we need to be able to capture data better. We need to be able to do interim analysis and take it with a grain of salt, but we need to ensure that research is integrated into our care so we can do that. And the other issue is that when you take care of patients with diseases you don't know much about, there are a lot of ethical issues that arise from it because there aren't set standards of care the way they are with disease that we know much about. And so you might already be experimenting, your care in some ways experimental. For example, there was a lot of concern in this particular outbreak in 2014-2015 that some areas are starting to use, some Ebola treatment units are starting to use medications that have shown efficacy in animal models, but had never been tested on humans, and just overwhelmed with the mortality, and seeing the scenario. Some centers actually started using experimental drugs that had not been approved for use in Ebola. Even if it was not as extreme and unethical as something like that, even choices like what intravenous fluids should be used, when do we start antibiotics, all those things were evolving standards of care within this outbreak, really highlighting the fact that as it is, a lot of these things are experimentation, even if you don't label them as research. And I think that in some ways, improving research capacity can improve care, and vice versa. The bringing that capacity and setting up those scenarios in a way that you can improve capture of data helps clinical care, but also improves research capacity, which in turn will feed back to care again. So I think in outbreaks with novel pathogens, we need to define outbreak response as a combination of research, public health, and care activities. So this is particularly for diseases we don't know much about. It is not common to many different things, but here we need to assign the right resources to begin with. We need to ask for more money, right resources up front before we get into the field. So those are sort of the factors that I think that we can continue to work on and we should really focus on as we expand the global health security agenda that I don't see currently on expressly expressed in the global health security agenda. With that, I want to end and I want to take any questions that you might have. Thank you. Can you guys hear me?
We can hear. Yeah, we can hear you just fine. Thank you so much. I think Clem, if you're there, I think Clem is going to moderate the Q&A session and bring in some of the questions if we had any from YouTube. Otherwise, I would invite anybody else to ask away and start a conversation.
All right, Dr. Bhadelia, thank you very much for that amazing presentation. I was looking on YouTube and we have quite a few people watching, but no questions yet. But I did indicate that all the questions should be submitted to YouTube for me to pass them on to you. But if any of the people on this call have any questions that they can go ahead and pose them to you right now. But I'll keep moderating the questions, looking up for questions on YouTube. But that was very, very wonderful. Thank you.
Great, I'm glad to hear. Are there any things that were unclear during the talk for you guys that you think that I might better express or clarify?
I think you did a wonderful job with an overview of kind of the global health security space, and I think your take on it is really unique in the sense of having that kind of clinical exposure, especially during an outbreak, in a setting that was kind of identified as the prime example of how global health security is central to our new approaches to public health threats. I wonder if I might just ask a question since we're not really getting any online right away. So there's this period of time that you identify in this timeline that you present from kind of the 2003 SARS moment until 2012 when we get the Ebola outbreak and the sort of global health security agenda. And I wonder, there's a lot going on in that period of time that people speak of now. So for me, I wonder, is there something different about the global health security that was being discussed in kind of 1994 with that sort of heavily UN framework of human security, and then the IHR revisions through 1995 and into, with SARS as the prime example into kind of Ebola? Like, does that shift from 2003 to 2012 really indicate something unique happening there?
Yeah, I think the one big thing that happened in there, of course, is the discussions about threats around novel influenza, like the H5N1 influenza, and a lot of discussion that happened in that interim. One of the larger discussions that happened was the threat of the biosecurity threat that comes from research itself on these pathogens. We have to work on these pathogens to be able to better prepare. And to do that, we need to know how they could potentially impact populations. But when you do that, some of what you can do is create research that's something called gain-of-function research. So it basically creates more dangerous pathogens than what exist in nature as a way of studying how these things can actually jump. And so a lot of discussion actually went in not just at the national level here, but internationally, because 2 labs did this with H5N1. And so I think the elements of biosecurity actually really expanded with the global health security to include more of research. Global health security and biosecurity had been thought about in terms of potentially intentional release of pathogens, bioterrorism and things, but really the idea, the fact that research itself, even good intentional, research with good intentions could create potentially threats, and accidental releases could really sort of have a big impact on the world. I think the world really started having a lot more of those discussions. I think that's one way that it expanded. I don't know if I'm answering that correctly, but so that's one way. I do think that it also, what I think is great about the new global health security agenda is it's really trying to take that identifying gaps in capacity and really trying to work on that and making it context specific. So just taking the principles that we talked about, but going beyond just saying you're required to do this. It's saying, what are you missing? How do we make this better? Now that we know that these are the main pieces that you need in any one healthcare system to really, improve the ability to prevent, detect, and respond.
Thanks. I think we have some questions on YouTube coming in, so I'll let them be handed over to you.
All right. So the first question we have is from Ricardo Milan, and he says, "You mentioned that in the previous outbreaks in Ebola, we failed to identify signs and symptoms in survivors.
Yep.
That we saw in survivors of the outbreak in West Africa. Do you recommend that we need to change how we can foresee, but how can we foresee the mistake we have not identified yet?"
Yeah. So there's, one recommendation that I had, I feel like that blind spot's going to continue to exist until we have better healthcare systems where survivors can be plugged into care so we can pick up those symptoms, right? That's the big issue. In the absence of that, when in the aftermath of what happened with the survivors and the new discoveries in this particular epidemic that happened in the setting of Ebola, a lot of researchers, for example, there was research coming out of South Africa that said that, we actually know the fact that Ebola can exist in the eye in survivors, and we had published this many, many years ago. That research, was out there. It's because there was not as much collaboration and conversation between researchers in South Africa and elsewhere. And so I think one of the ways that we can improve is create platforms that allow clinicians in resource-limited settings to really be able to better communicate with those that are working with this disease here, but also those that are working to prepare for outbreak response, as well as researchers, so that we are focusing on the right things. So I think those kind of platforms might help.
All right, so I think you just answered the second part of his question, because that part was, he said, I'm working with Zika control efforts at the moment. How do we know what gaps we need to fill after we have controlled the outbreak? So you just answered part of that rest of the question. Thank you.
Yeah, and in Brazil, in Recife, in that area, what was so great about the astute clinicians who were there is that they picked up the microcephaly, for example, in Zika, and have been sharing the information, right? That comes from, Brazil has a better healthcare system than West Africa has. That communication between clinicians in Brazil with researchers there, but also researchers here, has really helped us understand the way Zika is manifested. Other questions?
Thanks. Yeah, I wanted to, if I can take over, because I don't think we have any other YouTube ones. Do any of the other moderators have any questions? Jamesia?
Yeah, I actually have a question. I think it's probably one of the many elephants in the room. So as we in the US are moving forward to a new administration, what would be your suggestions in prioritizing or encouraging the new administration to continue to prioritize both the global health security agenda as well as public health programs?
Yeah, we actually had an entire discussion about this in my class last week about how the change in administration might impact this. And some of the conversations where one of the hallmarks of the platform that this particular administration ran on was decrease in big government, and also decrease in foreign aid and more focus on the domestic side. The issue is that, does that then signal cutting of resources for public health in general and foreign aid in general in developing countries, which of course, from everything that we've covered, we know that that's going to create the kind of vulnerability that will give rise to uncontrolled outbreaks. One thing that, we thought about is that the global health security there are a lot of detractors for global health security, those that say that it kind of leads to militarization of public health, and that's not the right way to go. Others that say that it takes away from other public health funding. One thing that might happen actually is that you might see more funding for global health security because it's more security oriented. At least that's my optimistic view, is that because this is so much more security oriented that you might see at least this part of the program survive, but we'll see how that plays out. I do worry even domestically if the domestic governmental funding for public health bodies decreases. Already, for example, with Zika, a lot of the vector control programs in the U.S. Have been decreased in funding in exactly the areas where we're most likely to see Zika cases. Areas where the mosquitoes, the Aedes mosquitoes, is most prominent. And so those are the very areas that are actually seeing those cuts in public health. If we continue to see that, we're shooting ourselves in the foot in terms of being able to handle new threats that cross our border. So my recommendation would be for the new incoming administration to really look at all those factors before they cut anything. And then, I'll put a plug in for climate change for the reasons that I talked about. All the devastation we're already seeing are from climate change dynamics that we put into play 30 to 40 years ago. As it is, we're looking at pretty ugly incoming 30 years because of all the damage that's been done in the interim. I really think that climate change is so closely tied to human health, and human health then, of course, to security, that we really need to look at climate change in that way.
Thank you.
All right, thank you. I have a question just based on going off of what you said earlier about how, because security is funded a lot in most countries, tying global health to global security might actually get funding. I think particularly in developing countries, especially in Africa, a lot of the governments put a lot of money in security, buying arms. But these countries, their military is not also known for being full of maybe global health professionals or scientists. As for instance, we have the Navy Medical Center here. Most of these countries don't have stuff like that. What would be a good way, in your opinion, where global health security could be framed or sold to such governments in a way to get more health funding through their security funding for their military?
Yeah, so if I get the question correctly, it is in areas and countries where there's already high securitization, but maybe not effective securitization, and not as much funding, how can we better improve the implementation of global health security to make sure that it's representative of all the things that we want out of it? Is that correct?
Exactly.
Okay. So I think that those that are, and I would say I have some issues with global health security agenda as well, because I think that the concept of idea of securitization is something that we need to do with care. There are multiple reasons for it. One is for the reasons that we talked about. When you securitize health, are you taking away from the idea of rights-based approach to health? Is now health not so much a human right, but really something that's driven by self-interest and national security? And are we changing the conversation in a way that might be detrimental in the long term? But beyond that, is including traditional security actors like military within global health security, which is, really one of the concepts that happens. And this was played out in West Africa, for example, with the involvement of the militaries in helping control the Ebola outbreak. There's a lot of distress in many countries with the military itself. Maybe because the governance and the management of those militaries have a history of potential contention with populations. And because of that, you won't get the cooperation that you're looking for. And so are you shooting yourself in the foot by involving traditional security actors? So that's two. The third issue is really that are you, by putting everything into the security bucket, infectious diseases are, sure, they're killing a lot of folks, but emerging infectious diseases and outbreaks are not the only thing that are killing people in resource-limited countries. Actually, the top causes of death are now shifting to be non-communicable diseases. So are you, by focusing particularly on these threats, taking away from things that are actually killing countries? Killing most people in the countries that we're talking about. So I think that taking one way to do this is ensuring that those global health partners that are part of the global health security are putting forth staff and representation from their own countries that are wide-based, that are community-based, that are healthcare-based and not just security-based, not just ministry-based. A broad-based representation from countries that are involved in global health security agenda can ensure that the right priorities are on the table. So I'm seeing some questions here.
So the next question, I'll go ahead and mention it for you. So it's a question about the role of the private sector collaborations and partnerships in global health security and how that's been changing or how it might continue to change in the future.
Yeah, I'm so glad you brought that up. I think some of the most innovative stuff is actually coming out of private sector, and particularly innovation around technology. Companies are starting to recognize the importance of ensuring social responsibility, but particularly in corporations that are involved in countries that are vulnerable to these types of outbreaks, they have an existing responsibility because their workers might be impacted by this. Their investment might be impacted by this. So Firestone, for example, is a company in Liberia, and it has had varying sort of degrees of cooperation because there's some contention in the country about whether Firestone's taking natural resources, but again, Firestone's also at the same time creating jobs, providing healthcare to some of their workers. And so the discussion is, during the outbreak, Firestone actually set up their own Ebola treatment units and had really great responses, mortality rates, improvement in mortality rates, and published that data. That kind of responsibility is great to see, and so we're seeing this, increasing ways of private sector to be involved. One is through innovation and technologies. Another might be through investing in global health security programs where their particular programs are, their particular investments are focused. And three, to take an active role the way that Firestone did. Again, a lot of contention about all that stuff that I won't go into, but there are multiple ways. And I think we've seen that evolution over time about how private sector has been involved. And do I see something else here?
I think that was it for the YouTube questions. I think your commentary about the private sector is really interesting in the sense of individual kind of private sector or company investments or responses to particular outbreaks, but also this perspective and preparedness kind of response from the private sector as it organizes around issues like the private sector roundtable and the
Yep.
GHSA consortium and these other kind of areas. I think the question that still remains to be answered seems to be, at least for them, kind of what channels are available for us to actually plug in our unique strengths of innovation and minimal bureaucracy and kind of the rapid mobilization. How do we actually, where does it go? And I think this is a big question for me in relation to kind of the global health security space, in the sense of who has stewardship of it. I think there's a kind of unanswered, lingering, open-endedness to that, which in one manner has actually been really good, but in another has been an area where people haven't been able to actually plug in their resources. So I wonder if you have any experience with that kind of space.
I feel your frustration about this idea of the fact that it's again, it's like sustainable development. It's a great idea, but what do you mean by that? It's like world peace. At some point, how broad do you make it? How narrow do you make it? And I think we do have a finite number of things now on the agenda, which is great, but each one of these things would take multiple lifetimes to accomplish, right? And so who does it? Who's responsible? Who's sort of taking notes to ensure that all the landmarks are being milestones are being met. So I agree with that. I think that having the separate consortium, as the ones you mentioned, are helpful. One actor, just switching a little bit, one actor that's not talked about, even though they're a part of the consortium as well, and their strength is academic institutions. Universities actually lead to, they are present in a lot of these countries and have existing collaborations that are ongoing. You know, they build capacity. Again, there's the issue of who owns the research that comes out of that, and that's something that we have to sort of focus on. But a lot of times in outbreaks, universities, academic institutions have actually worked as swing resources. For example, the Nigeria example that I gave, where Ebola was quickly identified, that was done at Christian Hoppy's lab at Redeemers University because he had that capacity, because that existed. And that was outside the governmental field, it was outside the private field, it was at a university. So how do we, another challenge is how do we ensure that we're linking, universities and academic institutions in the field as well, because they also provided a lot of my example in particular. They provided a lot of foreign medical staff and diagnosticians during this outbreak as well.
Yeah, thanks. I totally agree, and I think the conversations about the academic involvements, especially with your comments about R&D as being really important, I think that's been only narrowly discussed, and I think the points you raised today are really pertinent to broadening that discussion. So thanks.
Great, awesome. It sounds like we don't have anything else on the docket. Is that right?
I have just one final question, if I may.
Yes, please.
So following the joint external evaluation of the United States, there was a recommendation to have a more formal One Health strategy in the US. And so I know that you currently teach a lot of interdisciplinary courses, and the academic level, it seems to be a really large push to start engaging in this One Health model. As the next generation, how would you encourage us to move forward in our professional careers and still maintaining this One Health model, given the, I guess, disfragmented nature?
Yeah.
Now.
So this is actually one of the reasons I teach the courses that I do. I believe strongly that the issue is that we speak different languages in different sectors, and even if the intent is there, sometimes you miss the boat because you're talking about the same thing but using different terms, or you have completely different ideas of the same concept and you're not able to communicate that. I really think that one of the things that we can be better about as universities, but actually also as at higher levels of government, as State Department and such, is to integrate intersectoral education, to create the next professional, to create courses of study, projects that allow collaboration, and even beyond that, even before that, create common language. Create professionals that have common language and are able to understand concepts from different fields, even if that's not what they're working on. So the course that I currently teach involves international affairs students who will go into State Department, into international nonprofit organizations, World Bank, as well as medical practitioners and public health folks, particularly those that are involved in, some of those who are involved in veterinary studies as well. By doing that, you're allowing folks to talk about the same issues from different perspectives and build an understanding of where others are coming from. So I think that we need to get better about education early on, and then higher up already for those that are young professionals and already working in the career field, for governments and organizations to create opportunities so that you can bring in intersectoral development and discussion.
Thanks. I think that's,
Thank you very much.
An excellent point. Yeah.
Awesome. Thank you so much for having me.
Yeah, thanks so much, and thanks for bearing with our technical difficulties too. It's been an experiment, so I appreciate everybody bearing in, including the viewers, but especially you, Dr. Bhadelia.
Thank you for having me. Have a good day.
Yeah.
You too. Thank you very much.
Bye, everybody.
Bye-bye.